So you probably watched the part one, which was the initial management of knee ligament injuries. We spoke a lot about the anterior cruciate ligament. Henry is going to speak a little bit more about the other knee ligaments, main structural ligaments, and some of the surgical techniques. We're not going to go into too much of the detail, but enough so that you've got a good understanding of it, either from a rehab perspective or from a patient perspective. Actually, what are we doing? Why are we doing it? And some of those common questions in this that people may want to ask, I'll pick up and do the same as in talk one as we go through that. So Henry, thanks again. It's a huge amount of information and an afternoon of your time that you're giving us. Really grateful to that. Welcome back after our coffee break.
Thank you. It's interesting. You mentioned the surgical techniques. In my experience, there are two types of patients. The first type of patient says, when I ask them about what information they want to know, the first type of patient says, you're the doctor, get on with it, I don't want to know any of the details. And then the second type of patient says, oh, know exactly how you do it. Do drill tunnels. So, some of this will be for that type of patient.
Was that patient from the West Country, by the way, that one?
I couldn't possibly provide them. But yes, I'll load up my screen.
Perfect.
Shall I just?
Yeah, I'll turn off my mic.
Part one, we discussed mechanism of injury management, why the knee gets injured. This is more the gorier stuff on the actual surgery, but also to talk about the other knee ligaments, which we mustn't forget about. So we'll touch on the ACL surgery. I'll talk a little bit about rehabilitation, which is so critical at the other ligaments, and finally what happens when lots of the ligaments get injured. So we talked briefly before about surgical timing for ACL reconstruction. Now there is an early window for reconstruction, and the really top end elite athletes will fall into the category of being able to do it early. If you get the patient, if you get the athlete within 24 to 48 hours, before the knee really starts to swell and all the inflammatory mediators are released, you can get in there and do it. But most people, particularly in my practice, most recreational and non-elite athletes will get a reconstruction around about 6 weeks. You need to wait for the swelling to go down. You need to wait for the pain to go, and you need to wait for the range of movement to come back. And the catchphrase we use is when the knee is pain-free and mobile. If the knee is not pain-free and mobile, I will send the patient back to the physiotherapist, and I will say, look, we will meet again in a couple of weeks' time. It's very, very critical, this, because if you operate on a stiff, painful knee, you're likely to have a stiff, painful knee afterwards. So amongst the things that we do and we discuss in surgery, and the important things about getting it right, the first thing is graft choice. And I'm going to put up lots of pictures here, but really the most important thing is written in orange at the top. And what we would consider to be the gold standard, the best thing to make a new ACL, will be some tissue from the patient. So we will use another bit of tissue that's being used for something else and make it into an ACL, and we call that autograft. And here at the top of the screen are the two main types of autograft used here in the United Kingdom, one of which is the hamstring tendons and the other is the central third of the patella tendon. So this is tissue from the patient, goes back into the patient to make the new ACL. People often will ask me why can the ACL not be repaired? And I liken it to a guitar string. If you cut the two ends of a guitar string, they do this. They cannot be tied back together. It's a ligament that's under tension. The two ends come apart. They don't go back together. There is description in the literature of ligament healing, but it's extremely rare, and we know that. The other things you'll see in white are other things that have been tried. Allograft means tissue from somebody else, so with the benefit of irradiation to make it safe, these tendons from people that no longer need them. Young patients that have died for other reasons, we can use tissue from them. We can use tissue from animals. This has been trialed, and kangaroo, interestingly, has been trialed in Australia. And then there are synthetic ligaments, which have also been trialed. But I'll say it again, there's no doubt for most of us in the knee surgery world, we would agree that the gold standard is autograft. The next thing to consider is where to put the tunnels. And there are lots and lots of anatomical and clinical studies to show where to put it. We are getting better and better at this each year. You would be amazed at what a big difference a millimeter or two makes as to where you drill your tunnel. The tunnels are drilled through keyholes on the inside of the knee, and the new graft is then threaded up through those tunnels. There are various different ways of getting the tunnel position correct, one of which, as you'll see on the bottom left-hand corner here, is to use X-ray. The fixation varies according to where you are in the world and what your own personal preference is. The different types are suspensory, where a button will hold on to the graft; aperture, which is where you use a screw in the tunnel to hold the tissue in the tunnel, or a combination of both. And what you'll see here in the video on the right-hand side is there's the button. It's made of titanium, pulling up the new ACL. On the left-hand side is the PCL, the posterior cruciate ligament. That's the new ACL, the ligament being pulled into place. When the pen mark disappears, it's in the right place, and it's fixed then and almost ready to go. My advice to training surgeons is pick one device for each side and stick with it. Changing techniques, changing devices invariably will lead to more errors. There is a big knee meeting going on in America as we speak. It's been scheduled for this week, and I have no doubts this will be being discussed. This is the hottest topic in ACL surgery at the moment, and it's a topic on whether or not to augment your ACL reconstruction with an extra procedure. And there's lots of research that's come out recently from very big centers around the world to suggest that you can reduce the re-rupture rate of your ACL by performing a procedure on the outside of the knee that we call an extra articular procedure. And the biomechanics of that are illustrated here, and it's to do with the control of rotation. On the left-hand side, you will see a picture of the tibia, and the tibia and femur rotate together. Now, if you're controlling rotation, it's all about the distance from the pivot point, which is represented by the dot there. And the ACL on the left-hand side is controlling rotation with a relatively short lever arm because it's in the middle of the knee. If you put in an ACL and then on the right-hand side, another orange line, which is another reconstruction on the outside of the knee, you get the benefit of a much longer lever arm.
Can you explain that one, Henry? If you come out of the, if we come out of the presentation and just show me that with your labeled hands, what you mean by that?
So what I've done here, Justin, is I've written F for femur and I've written T for tibia. As we have been discussing, the ACL prevents the tibia subluxing anteriorly on the away from the femur, but also it's controlling rotation, internal rotation of the tibia. Now, the ACL, as we were looking at earlier, is on the inside of the knee, represented by this green tape here. And I don't know whether you can see the orange dots, but I've put the orange dots in representation of where you would attach an extra ligament on the outside of the knee or an extra restraint. And if you look at the control of the internal rotation of the tibia, you can see that if you were to put something between those two orange dots, you've got something extra to control not only that rotation, but that movement forwards of the tibia. There are two ways of doing this, and I suspect they will be arguing in the States about this now, about which one to do. Every surgeon has their preference, but Firstly, there's an anterolateral ligament reconstruction, which is putting back a supposed anatomical structure. And secondly, it is using a strip of tissue that is already there here on the right-hand side, known as the iliotibial band. And both of these have been described before. The left-hand side one is an American chap called Rob Laprade's work. And on the right-hand side, this is diagrammatic form of how to perform this extra-articular reconstruction, whip stitching a bit of the iliotibial band and tucking it under the lateral collateral ligament and fixing it to the femur, or suturing it back on itself. Now, the interesting thing about these is that they've been around for some time. If you look at the dates of when these were originally described, these surgeons thought about these things many years ago. It's often very interesting in surgery how we go back in time and relook at things that have been done before. Why do we not do this on every patient? It's perfectly reasonable for each patient to ask their surgeon, why are you not doing this if it halves the re-rupture rate? We don't know yet what the long-term effect of doing this. We certainly know that the patients will have another 20 minutes of surgery as a result of having to do this extra procedure, which will slow the rehab down initially. There's also a scar. You can't do it without a scar, whether it be more keyhole scars or a longer one. And we don't know yet the long-term effects of having this extra constraint on the outside of the knee. We've got good short-term data, but there's really nothing long-term. So Justin, I know that your interest in rehabilitation is particularly with this. This is something that you're very much part of. And there is no doubt in my mind that this surgery, this does not work without proper rehabilitation, proper supervised rehabilitation with a physiotherapist, with a sports doctor like yourself, looking at how these patients are doing. When I consent patients for surgery, I will say to all of them, 50% is the operation, 50% is the rehabilitation, and one does not work without the other. So these people, these patients, anyone undergoing ligament reconstruction must be really, really focused on their rehabilitation. And as discussed, 50% is success. I think we've probably worked out that goal-based rehabilitation is better than time-based. So that would suggest that you've got to achieve each goal before you move on to the next stage, rather than it just being a time-based 3 months, 3 months, 3 months. And the physiotherapist must be looking objective and subjective data. And then we look at return to sports testing, which is only guiding us. It's not giving us the answers, but it's guiding us towards whether or not patients are ready. And these are some of the things that the physiotherapists will be doing with patients, comparing the injured to the uninjured knee to see how good the strength and the balance is prior to them going back on the football pitch, going back on the netball court, or going back to their sport.
Yeah, those are really nice images, and if just go back to those, Henry. And what we're doing for anybody from a patient perspective, what the physio is showing there is mimicking the sort of movements that would occur on in a sport and an active situation, but in a controlled way. You've not got a competitor, opposite player running towards you. You're not distracted by what you're doing with the ball, who you're passing to next, and if you're going to go back into multi-directional play, you need to be able to do that in that controlled environment. So yeah, lovely couple of picks there. And
it's fascinating for a surgeon going to see these people doing this, because this is where the last bit of the journey ends. And if for me, if you haven't been through this testing, then I don't know how you can know whether or not you're ready.
I got a question regarding that, Henry. We've just come out of the couple of ACL questions, but if we just come out of the presentation, we use the word surgery. We think surgery is gory. Actually, with ACL surgery, knee ligament surgery, you've got a tourniquet on the leg, haven't you? So you've got something that's tight around the leg that reduces blood flow and blood loss, and whilst you're operating. How long would an ACL operation, anterior cruciate ligament replacement operation take usually?
It depends mostly on whether or not there's any work to do to the cartilage or the shock absorbing structures, we call the meniscus. If there's work to be done to those, it takes longer. But if there isn't work to be done to those, an average operation takes about 40 minutes.
Okay.
One of the things we're very lucky in today's world is we have wonderful technology in surgery now. You know, our cameras are amazing. Our instruments are purpose built to do certain things, and they're built to do certain things through very small holes. So it's a technique. It's a surgery that's been refined over the years, and we have the benefit of that.
And one of the other slides, when you were talking through allograft, autograft, so with the two grafts, that the gold standard grafts, either the hamstring or the bone patella bone, we talk about, if you take the hamstring, that semitendinosus muscle, what sort of percentage of power loss would you get from that hamstring muscle, would you expect?
I think the objective studies have shown around about 8% overall. So the strength tests show that sort of deficit, and that's after full rehabilitation. So if you were an Olympic sprinter, you'd be very disappointed with losing 8% of your time.
Yeah.
But if you are a recreational athlete, you probably won't notice. I mean, there's no doubt that if you look in professional sport, if you look at professional football, particularly, if you look at the likes of Michael Owen, you will know, and he will probably tell you, that they do lose that very, very sharp edge of speed and acceleration. And I think that there's no doubt there is a deficit, sadly, but at the same time, there's a large number of professional athletes, elite athletes, that do return to their previous level or very near. So I think it's a remarkable success story.
And so bone patella bone, so that is taking a plug of bone from the top of the bottom part of the kneecap and a plug from the tibial tuberosity and a section of the patella tendon. Why do you do one type of graft over another? What makes, as a surgeon, why do you decide to do that?
Well, that's a really excellent question. And as I say, I was mentioning knee meetings earlier. Surgeons will argue for hours about this, hours and hours and hours they'll spend. A lot of it is training. It depends where you trained. A lot of it is personal preference, what you think you're good at. I think that all surgeons should accept what they're good at and probably not accept what they're not good at. And I think that those are the two major factors. There is a lot of new data, and there's a lot of new data to suggest that hamstring autograft is not so good in young athletes, particularly the teenagers in early 20s, and the patella tendon is a better graft for those people. But it's not 100% clear cut. Again, a lot of it depends on rehabilitation. It depends on the type of patient, and matching those variables accurately is very difficult. But I think that most surgeons who are interested in this sort of surgery nowadays will accept that they may have to tailor the graft to the patient. And I think that's what a lot of us are doing these days. We're trying to find, the right graft for the right patient. So I think, in a broad answer to your question, I think you should be able to do both, potentially offer both. Yeah. But again, a lot of it is down to the actual patient and a discussion that you have with the patient.
And the images we saw of the patient doing the multi-directional tests and returning back to sport, I'd want to talk a little bit about the integration of the graft into the knee, and why surgeons get so understandably protective about the operation. So the rehab's part of it, the surgery is a big part of it, obviously, but most, as I understand it, most ruptures occur within the first 12 months. Is that right? Most re-ruptures or graft failures?
Yeah, I mean, it's interesting you mentioned that. There is a distinction between re-rupture and failure, and I think that failure could be considered failure of the actual not the surgical procedure, but the whole process, i.e. the patient's had a reconstruction, they've done the rehab, and yet their first game back, it's torn. Now, a lot of people would consider that to be failure. It break the patient and the surgeon's heart, but that is what happens.
Yeah.
Re-rupture is often a case of it tearing again, probably for the same mechanism, probably for the same biology, probably for the same reason it tore first time around, which might be to do with the patient's biomechanics. And that is often later. Those types of patients have played 10, 15, 20, maybe even 30 games before they re-tear. And so there is a distinction. But yes, if you look at the data, the surgeons that have long series, the re-rupture rate is 2% in year 1, 2% in year 2, and then every year after that it tends to be about 1%. Now those figures are very rounded up or down, but generally I think that you're absolutely right. The first 24 months particularly is your high risk time, and if you get over the first 24 months and you've got 20, 30, 40, 50 games under your belt, I think the chances of you doing well are much, much higher.
And another technical question: once you've put that graft in and you've that's been bolted or you screwed in place, from a tensile strength perspective, is that up to maximum tensile strength? Does that change?
It is. Well, it does change. That's a really excellent question. I mean, we know from studies in labs, if you take a hamstring tendon graft and you put it into a cadaveric knee, a knee of someone who's died, and given their knee for scientific research, you can put that through a whole load of strength tests to see. And the ultimate strength when it goes in on day one, so that lab study shows that the new ACL will restrain about 2,000 newtons, so about 200 kilograms. So it's very, very strong when it goes in. Now, what happens after that is that the body breaks it down a bit. The biology goes on inside the knee. Yeah. The knee changes the tendon into a ligament, and we sometimes refer to this as ligamentization. And during that process, the blood vessels are growing in, they're breaking down the protein that's in that ligament and turning it into what it considers to be something functional. And that process takes time. And we think that it's very strong at the beginning. It's much weaker between about 6 and 24 weeks, and then it gets stronger again as the body lays down that protein, that collagen. So there is a risk window, if you like, between 6 weeks and round about 4 months, where if you do something stupid, then that is bad. But you touched on it earlier, that does depend on graft choice, and that is the hamstring tendon graft. The patellar tendon graft, I think, incorporates quicker, and I think that those people can start to do more earlier. I mentioned a famous orthopedic surgeon, a famous knee surgeon earlier, called Shelbourne. I've been to visit him. He treats mostly basketball players because of the part of America that he works in, and he has them back on court after 3 to 4 months. They're not playing, they're not competitively playing, but they're training, and I think that's probably because of the accelerated healing of patellar tendon over hamstring.
And what's the quickest? Let's say I'm sorry, I'm hijacking your talk, but these are really interesting questions, interesting, amazing answers. If let's say we had a £50 million player and we wanted to get him back as quickly as possible, what graft would you choose, and what would be the absolute quickest you as the surgeon would get that player, get that athlete back onto the into competitive full international play?
I think the quickest that you could rehabilitate, you could operate, rehabilitate, and get a player back on the pitch would be 7 to 8 months. I think that before that, the risk is too high, and I think the contract to that player would probably forbid it. A patellar tendon graft is probably, as mentioned, going to heal the quickest, and for a professional footballer, probably the graft of choice, but I use the word probably because it's not cut and dried, that, but in direct answer to your question, not before 6 months.
Yeah.
Depending on other injuries to the knee, cartilage injuries, meniscal injuries, other ligament injuries, up to 12 months. And there are some players that you don't see for 12 months, and that's for good reason. They have other problems along the way, and they usually are other intra-articular injuries.
And they got to hit their markers. They got to hit their rehab markers. As you said, it's not.
They have, and their physiotherapists. If the physiotherapist and their surgeon are not happy, then they shouldn't play. And I think that the stakes are very, very high with these multi-million-pound contracts, and I think they've got to get it right, and quite rightly so.
Right, that's my ACL questions. Apologies for hijacking. I'm going to let you crack on.
No problem. So we'll go back to the screen share, and on the screen share now we should have a slide on the posterior cruciate. So we were going to talk about the other ligaments. We mustn't forget about the other ligaments. They are equally as important, although sometimes not so commonly injured. The posterior cruciate ligament is the ACL's partner. It is the strongest ligament in the knee. It also has 2 bundles. And going back to my fists again, it's the primary restraint to posterior translation of the tibia, as opposed to anterior translation. So when you've ruptured your posterior cruciate ligament, the tibia tends to sag backwards, and it also has some control in external tibial rotation, as opposed to, as we've discussed with the ACL, internal tibial rotation. So really it does exactly the opposite of the ACL. There are 2 main mechanisms of injury of this ligament, the first of which we used to see a lot before the safety of cars got better and better, and we called it the dashboard injury, which is a direct blow to the front of the tibia when the knee is bent, like the picture in the middle here. The force from the front of the car crumpling causes the posterior cruciate ligament to break. The rugby players tend to suffer this when they're being tackled. The tackle from the front, like the picture in the bottom left-hand corner, we see in rugby union, rugby league. So we see more PCLs traditionally in rugby players than footballers. But then the second mechanism is a very famous footballer on the right, Zlatan Ibrahimovic, and this picture of him hyperextending his knee was how he tore his posterior cruciate ligament. And that is what we see as the other main mechanism of injury. The examination of the posterior cruciate ligament is actually quite a lot easier than the anterior cruciate ligament. The tibia tends to sag backwards. And again, examining both knees is absolutely critical to pick this up. This video, if it runs, will show quite a significant posterior cruciate ligament. This is what we call a grade 3, and you can see the tibia subluxes quite significantly back on the femur, up at 90 degrees. There is a classification, and the management can be guided by the classification. The interesting thing about the posterior cruciate ligament is that, unlike the anterior cruciate ligament, it very, very rarely needs to be reconstructed. And the only ones that need reconstructing are people that have failed conservative management, or often as part of a multi-ligament injured knee, so other ligament injuries. Generally with posterior cruciate ligament injuries, even in professional athletes, it's rehabilitation first, and then to consider reconstruction if that fails. And the reason this has changed is that the technology in rehabilitation and the technology in bracing for these injuries has increased dramatically over the last 10 to 15 years with sports science. The surgery is technically challenging. The anatomy of the knee is such that all the important parts of the knee are at the back. Surgeons call this area tiger country, and you do enter tiger country when you perform a posterior cruciate ligament reconstruction. So it's technically a very challenging operation. There are risks, and there aren't many surgeons, particularly in this country, who will do more than a handful of these operations in a year. Onto the medial collateral ligament. Now, this one is the physiotherapist's friend. The medial collateral ligament of the four main knee ligaments is the one that heals best. It has two components. It has a deep and a superficial. It's like a strap on the inside of the knee, and it is a restraint to valgus stress at all flexion angles. They heal very, very well in most cases. Very common in football and very common as part of a combination with an anterior cruciate ligament injury. The management nearly always is bracing. Bracing, to the time and the type of brace depends on the grade of the injury. Grade 3, when there is a complete tear, often requires bracing for longer, but the sprains and the partial sprains will heal fairly quickly and fairly reliably in a brace. Very occasionally they require reconstruction, and I'll show you a picture of that in a minute.
Henry, can I ask, the brace there is for 30 to 90 degrees. Could you explain why the knee is restricted in that range?
If you see a patient with a knee injury that's fresh, that's acute, it's been a few days, nearly all patients with this injury will hold their knee at about 30 degrees. You don't see people with a straight knee when they're lying on the treatment couch. They're holding it, protecting it. And the reason for that is when you straighten your knee, the medial collateral ligament tightens and it's at its tightest in full extension. So getting the ligament to heal reliably and getting the pain away from the patient means just breaking it to that 30 degrees makes it much more comfortable, and it slackens everything off on that side a bit to allow it to heal.
Okay.
So I favor a brace at 30 to 90 degrees. It can be put out straight after a few weeks, but the initial period, it's much more comfortable to just have that little break in it.
And how long should you have a brace on for? So for grade 1, we know can heal fairly quickly. Grade 2, how long should you be in a brace for?
It really depends on pain. And I think that the patient will guide you as to how long it needs to be on for. As a guide, 4 weeks for a grade 2. But I think if they've got ongoing pain, I think you can brace them up to 6 weeks. The pain will tell you how well and how quickly the patient's healing. I want my patients with a grade 3 to stay in a brace for 6 weeks, because I think that is how long a grade 3 takes to heal, and it is better to protect it during that time. So for those patients, I ask them to wear it day and night and only to take it off when they have a shower. And when they're in the shower, they keep the knee a little bit bent.
And out of interest, are you using radiological grade 3 or clinical examination grade 3?
Both. I mean, I think the clinical examination grade 3 unquestionably will need 6 weeks of bracing. There is no restraint at all there. But the clinical examination for me is more important than the radiological examination, because sometimes what's described on the MRI scan as a grade 3, you examine the patient and actually it's stable, the MCL. So I'd go on clinical examination grade 3 more than radiological.
And your laxity, your 5 or 10 millimeters lax, just explain where that is. That from the midline, or is that gapping at the medial aspect of the joint? What do you mean by that?
But that's gapping at the medial aspect of the joint from the normal position to the abnormal position, and you can only make that assessment on your examination of the other knee.
Okay.
So that is the increased laxity compared to the other knee.
And in terms of recovery times, grade 1, 2, and 3, what sort of times would you? People maybe said they've got a grade 2 injury, grade 1. What sort of return to sport, back to full fitness? What sort of times would you?
Grade 1 to grade 2, 4 to 6 weeks. 6 weeks playing. Grade 3 injuries often out of the brace at 6 weeks and then rehabbing for another month after that. So probably a 10-week rehabilitation for that. But again, that should be guided by the physiotherapist if they're experienced, and guided by the patient how they're feeling. Footballers particularly, they kick with their instep. Rugby players, you will see they place kick with their instep, and those people can have problems kicking because of the pain from the MCL tear. So to be guided by that is really important. MCL, the lateral side of the knee is complicated. And the reason it's complicated is there's lots of different structures. And while we know the lateral collateral ligament is an important structure, there are lots of other structures around there that augment it and help it, if you like. And, you know, this is really for an anatomy talk. And those that are interested in this, there are lots of other talks on this, but really the three main structures you can see in this picture are the lateral collateral, or it's often referred to as the fibular collateral ligament, particularly across the pond. The popliteus tendon we know is extremely important, and the popliteal fibular ligament. And there, as I say, there are lots of other structures. This gets injured often as part of a multi-ligament injury. Will often go with the ACL and or the PCL, and the diagnosis is initially a good clinical examination. Patients often present in plasters or braces, and you know the good doctor, the good physio, will examine the patient without the brace on and have a really good look. And often you will see bleeding from the posterolateral side. And so if there's a lot of bruising and bleeding on that side, you need to be very suspicious of posterolateral corner injury. X-rays can be very helpful, and particularly here you'll see a stress X-ray. Knee surgeons are using stress X-rays more and more because it's, you know, it is objective proof of a ligament disruption, and you can put that down in the notes and keep the X-ray to show that's what's happened. Clinical examination, X-rays, and of course MRI scan. There's a very lovely study from the States, a group led by another very well-known soft tissue knee surgeon, Rob Laprade, that shows the differences when you cut the ligaments in side-to-side stress X-rays. And if that's something you want to look up, he's very generous, Rob, with his research, and you can download the paper from his website. So management of this very much depends on how it presents, and you know this is a talk, you know, for another day. But you know, like everything, it's recognition and discussion with somebody who treats these injuries. You can repair the lateral side much more commonly than you can with the other ligaments. You can actually stitch things back together, or you can reconstruct. There are various surgical techniques, and again, I won't go into this, but the three most common techniques used in most parts of the knee world are here, and most surgeons will use one or a combination of these techniques. And then really the final part of this talk is what happens when more than one ligament goes. And you know, the first thing to say about these are very serious injuries. This is where the knee dislocates, as in the X-ray there, and these are a big problem for the patient. And you know, when people ask me, will my knee ever be the same again? Sadly, you know, very sadly, when you have these injuries, the knee never is the same again. We're good at reconstructing one ligament, but when it's lots of ligaments, you know, it is the damage is very much water under the bridge. There is a classification of knee dislocations depending on what goes. There are various patterns that can be recognized. The management for interested surgeons, paramedics, physios is really immobilize and get to a center that very quickly that looks after these. Rationale for surgical management, well, we're learning more and more over time, but certainly as knee surgeons, we think it is better to operate on them than to do what orthopedic surgeons did in the old days, which was put them in plaster and, you know, wait and see what happens. So we have recorded good functional outcomes for surgery. The surgery is challenging, and certainly of all the things I do, this is the most challenging type of operation that I will do. I prepare well in advance, and usually thinking about it most of the night before, and then in the morning, while the anaesthetist is putting the patient to sleep, getting the patient ready for surgery, I write a list of what I'm going to do. And you can see there's quite a lot of steps. And you know, the analogy I use is, you know, people often think that in the arts world, actors particularly, it's just natural talent that they go out and deliver their performance. But I think the good actors I know some of the good actors spent hours and hours and hours meticulously preparing. And I in this type of surgery, I think it's very, very important that. So I make a list, and I often write it on the wall of what I'm going to do and how I'm going to do it, because it can get stressful, and it's good to be able to refer to that if needed. And it also will let other people in theatre know what you're doing. So planning is absolutely key. There are lots of steps. So I'll just show you a few cases just for interest, and you can see how badly these injured. Both of these patients involved here, I'm pleased to say, have given permission for these to be shown. The first is a professional wakeboarder. This is him landing from a jump during training. Because of the splash, you can't really see, but he puts up his hand to indicate straight away that he's injured himself quite badly. Here he is, Ryan, poor chap, came in, and I'll run these MRI scans. He had a very significant knee injury. Here on the left-hand side, we're going across from the side. If you look at the front, he's torn his patella tendon off. He's also got huge bone bruises here on the lateral side, indicating ACL rupture. This is an impaction fracture here. So ACL rupture. And on the front view, this is the complete distal medial collateral ligament injury. Plus he has a posterior root tear of his lateral meniscus. So, you know, we assess these patients, make a list of what they've done, and then work out how to do it. And with multi-ligament injuries, we often decide to do all the surgery in one go or stage it. And with Ryan, I chose to stage it. So initially I repaired and reconstructed his patella tendon using a hamstring tendon autograft, as we discussed earlier, and then repaired his medial collateral ligament, braced him for 12 weeks, and then brought him back another day to do the second part, which was his anterior cruciate ligament reconstruction and the repair of his lateral meniscal root. So that was done at the second surgery. These patients need a lot of help with regards to physiotherapy and time, and often social and mental support, because it's tough for them, particularly professional athletes. And I'm pleased to say, you know, he got back to wakeboarding, and indeed has sent me some pictures of him winning some competitions again. The second case is a lady who injured her knee aged 29 on trampoline, and you'll see from her MRI scans huge amounts of bruising, which is represented by the white. Her lateral meniscus was balled up at the front of the knee. Medial collateral ligament, which was here, is completely gone. And then looking from the side, here's the lateral meniscus, which part of it should be back here in the middle of the knee. No ACL, no PCL. It's torn off the back. So bad injuries, complete ACL, complete PCL, complete MCL, and partial tear to the other side, and a complete lateral meniscal tear. So absolutely devastating injury to the knee. Impaction fractures the lateral femoral condyle as well, which are very, very painful. And often we try and work out whether to stage or go ahead with all. So for this lady, I did it all in one go, reconstructing all the three main ligaments torn. She had her meniscus, the cartilage, removed from the lateral side, and she went on then to have a bit more surgery. She had a manipulation for stiffness, and then she was referred to one of my colleagues, Mr. Tim Spalding, who specializes in meniscal transplant up in Warwick. I sent her up to Tim. He did a meniscal transplant, which is amazing surgery. And, you know, she's done well. This is her doing piston squats, I think these are called. And, you know, she has worked really, really hard over a period of time to get back to that. And, you know, the most important point to make with these is that these are very, very bad injuries to the knee. And in order to get anything like a near normal level of function, they have to really, really go through the ringer with regards to the rehab, and give it time. So in summary, the management approach is, you know, get things done early, things that will heal. I don't like to operate for more than 3 hours. They usually take 2 to 2.5 hours. It's not good for the leg, in my opinion, to operate for longer than that. And then do what you can to allow early and aggressive rehab. And, this is where you come in, Justin. These people need to be supervised through their rehabilitation. And finally, I bring the patient's expectations down a bit with regards to these injuries, not because, I want to be gloomy for them at all. It's just I want them to be realistic about where they can get to after these bad injuries. So I'm going to.
And those are just to say, your multi-ligament, the large ligament in injuries, as say, don't return
2
back.
or 3 of the main knee ligaments gone, and the knee has dislocated. So I draw it to a close there with a lovely picture of Windsor Castle in the evening, which I see where every day traveling between the 2 hospitals I work in.
Henry, that's really, really good. Thanks very much for both of those talks. If you're listening to part 2, please go and listen to part 1, which is more about initial management and assessment. That's fantastic. It's really good to have a experienced knee surgeon like yourself sit down for a couple of hours and just going through all of those questions. So Henry's Twitter feed is or Twitter handle is at Henry Knee. Is that correct?
Yep.
And contact him through that way, and there's a link on his profile to for further information if required. So thanks again, Henry Bourke, and everybody, whatever day it is, it's weekend time here. Have a great weekend, everyone.